Friends Research Institute, and I am also the director of the Combination Prevention Core with UCLA CHIPTS. And it was through the Combination Prevention Core during our meetings that we started talking about telehealth in the early part of the COVID-19 pandemic, as things were just shifting and we were all kind of scrambling to figure out how to continue our work and provide services to our participants and do the best work we could, given the fact that we were in the midst of a global health crisis. And in these conversations, it became clear to us that telehealth worked for some and not for others. And we continue to have this discussion over the course of the past year until it got to the point where we thought, let's open this discussion up. Let's have a broader conversation. Let's have some kind of a mini conference on telehealth. And that was the birth of what we are experiencing at this moment. The agenda for today is we are going to have a keynote speaker. We're going to have two panels, one that's going to focus on clinical care and then one that's going to focus on research. We are going to have a video of consumers talking about their experience with telehealth. And of course, the highlight of the day is going to be the virtual raffles. There's going to be 3 raffles and prizes are going to be given out to those that claim their name. So we are really excited for what's going to unfold today. I do want to state that yesterday we were all in awe of the fact that Juneteenth became a national holiday, and that from this moment forward, we will be celebrating and honoring and recognizing that day. And certainly, had this conference been planned in 2022, it would not have been planned on this date. And we also recognize that now some agencies and organizations are shifting for today to be their holiday. So we're recording this conference so those can view it at a later date. But I didn't want this opportunity to pass without saying that this is really a monumental day in our history. And as we move forward, it certainly will be a day that we take a moment to reflect. So with that, I'm going to turn it over to my colleague, collaborator, and close friend, Dr. Landovitz.
Thanks, Dr. Reback. I just want to add my welcome to Cathy's. We're very excited to have this conference really as a dialogue. We have assembled a really outstanding and exceptional group of presenters for our panels, our keynotes, and you'll be hearing some really interesting consumer perspectives on the use of telehealth, both for clinical services and for research participation. And hopefully we can outline what the knowns and unknowns of a research agenda, both for clinical services and for conduct of ongoing investigation during these unprecedented pandemic times as one of our outcomes of this conference. So please post questions, thoughts, comments in the chat function on Zoom during each panel presenter's presentation and also during the keynote. If there are specific questions for our presenters, we'll try and address them after each person has spoken. And if for some reason we're unable, because of time constraints, to get to some questions, we will work on formulating a Q&A response document that will get out to all participants afterwards. So we apologize in advance if the sort of compressed timeline doesn't allow us to address everybody's questions and thoughts during this conference. There are continuing education credits that are available. Those who need or are interested in credits, please register with the Pacific AIDS Education Training Center. If you're not sure how to do that, it was in your invitation to this conference registration. Just please post in the chat that you still need that information, and we'll get that right out to you. With that, I am incredibly honored and excited to introduce to you our keynote speaker, Dr. Brian Wood from the University of Washington. He is an associate professor of medicine in the Division of Allergy and Infectious Disease at UW, and he's a faculty trainer for the Mountain West AIDS Education and Training Center, the sister group of our local Pacific AIDS Education Training Center here in Los Angeles that we collaborate with closely. His clinical work focuses on primary care for people living with HIV or at risk for HIV, and has a really profound interest and expertise in telehealth and telehealth care access and health equity. He's the chair of the Infectious Disease Society of America's Telehealth and Emerging Technologies Work Group, co-chair of the University of Washington's Digital Health Equity Collaborative, and medical director for the Mountain West AIDS Education and Training Center's HIV Project ECHO telehealth program. On a personal note, Brian and I trained in the same infectious disease and HIV training program a million years ago, although he's much younger than I am. Although we didn't know each other during our training periods because we didn't overlap, we've had some really exciting opportunities to collaborate since then. And it's a real treat for you all to be able to hear him speak. We're really excited he was able to join us today. Brian, the floor is yours. Thank you so much for joining us.
Rafi, it's such an honor. And thank you so much, Dr. Reback, Dami, and the whole team for inviting me. And thank you everyone for making time to be part of this dialogue today, and made even more special because it is such a historic day, as Dr. Reback was describing. So thank you all. And the goal here really is for this to be a dialogue. So I am going to present some perspectives on telehealth and health equity or health disparities, with a focus on how they overlap and how they are dependent on one another. And I very much look forward to hearing from you, your questions, your comments, and all of the input today. I don't have any disclosures or conflicts. First, some terminology. The semantics and terminology here get confusing, and terms are used in a variety of ways. When I think of telehealth, I think of that as a broad umbrella term that describes any sort of electronic interaction. We often describe these interactions as being synchronous, meaning in real time. So the real-time video visit, for example, or an audio-only phone visit, which we will be discussing a fair amount. Various forms of remote monitoring also fall into that category. And we discuss asynchronous modalities. This might be an electronic consult where data is reviewed and a response is given by a specialist after an amount of time. Or one thing I think is very important and plays into the disparities in access and usage of virtual healthcare tools is use of the online patient portal, the patient who messages me an issue or requests their prescriptions online. At the bottom are two examples of colleagues doing video visits prior to the pandemic, prior to the widespread implementation of video visits. On the left, my colleague, Dr. Steckler, connecting with a health educator at one of our local bathhouses, getting ready for a PrEP visit by video. And on the right, a colleague who has been doing follow-up for individuals with burns by telemedicine for several years. But as you all know, there's been a real explosion in the use of telemedicine, and I will use telemedicine specifically for video visits, and I will try to be clear as I go forward. There has been obviously a huge explosion since the start of the pandemic, but as Dr. Reback was describing, not everyone has access, and this is one of the big reasons we are discussing equity today. If we look at some data for what has happened since the pandemic, I'll draw your eye to the black line in the center here, and this is data from a CDC MMWR. The black line describes percent change in telehealth encounters, and you can see here in the middle, first community spread of COVID-19 in the US around February 2020. March 2020, you can see a marker for implementation of the CMS, that Center for Medicare and Medicaid Services waivers, the emergency waivers that were put in place to promote and allow video visits. And this was huge. I can't understate how dramatic this was. This allowed seeing patients by video if they were at home, which we were never previously permitted to do, seeing patients by video even even inside metropolitan areas, which was never permitted, plus a number of other dramatic changes, including reimbursement for phone visits and more support, or an easier process to see patients across state lines. There were changes at the federal, the state level, as well as with commercial insurers. Co-pays for video visits were waived, all sorts of changes, which frankly we had been advocating for years, happened almost overnight, with the goal of promoting use primarily of video visits, but telehealth in general, to help people keep engaged. Now, again, when I describe telehealth visits, I use that term to mean video and phone. And I think there's some important data when we break down the differences or discrepancies between use of video visits and use of phone visits. Here I'm showing you data from 41 FQHCs in California. What you can see in the blue bar is overall volume of visits. On the left for primary care visits, on the right for behavioral health. And from the blue line, you can see that the overall volume of visits really did not change. In fact, for behavioral health, it has increased over time. This is data from February ending to August 2020. But if we look at that in more detail, the orange line is face-to-face or in-person encounters, which you can see dropped dramatically. The brown line at the bottom is video visits, which really only increased modestly. And the dark line here, the blackish line, is phone visits. And you can see that really what offset or replaced the face-to-face visits has been primarily phone visits, despite all of the support to get people on video. And so I think we have to step back and ask the question about why. This is for general primary care and behavioral health. I'm showing you some data here. This is not yet published data from our clinic here, our Ryan White HIV treatment clinic here in Seattle. And what you can see here is, again, looking at the overall size of the bars over time, not a dramatic difference in volume of visits, though we did drop off there, March, April 2020. Blue indicates visits completed by video, and you can see there was a modest uptick. About a third of our visits early in the pandemic were by video, and that's trailed off and plateaued at around 10 to 20% of our visits. Whereas phone visits in orange really have been a critical source of visit for patients to stay engaged. 50% or so of the visits we completed in our outpatient HIV practice early in the pandemic were by phone, and it's leveled off somewhere around 20% of visits. So again, despite all of this support and encouragement for video visits, a lot of people are relying on phone visits instead, or they're still coming to care for face-to-face visits. Now, I would never argue that all of our visits should be by video. I think there is an appropriate situation for a video visit, but I do not think every encounter should be by video. For me, I always consider, is it medically appropriate to have a visit by video, or is there an indication that I really need to see a person face-to-face? And that primarily for me involves, do they need a physical exam and other factors? But I would argue that video visits are important and offer benefits and advantages, and that everyone who wants a video visit should have equitable access or reasonable opportunity for it. When we think about benefits of video visits, particularly since early 2020, I think the one that quickly became prominent was helping individuals maintain social distancing, stay safe, especially individuals with elevated or disproportionate risk of severe COVID-19 illness. So it helps us allow patients to avoid the crowded spaces and the transportation, but also thinking longer term and bigger picture, it certainly helps reduce access barriers, transportation, missed work, child and other family care needs. I also think the reality is for some individuals coming to our HIV clinic, coming to our PrEP clinic still does bring up stigma, and we still have individuals who insist on coming into clinic but through the back door, and individuals who avoid the waiting room because of the stigma. So I think there are potential reduced barriers in that aspect as well. The other thing from a provider perspective that I have reflected on is when I see a person by video, I do get more insight into their living situation. It's almost like a mini home visit. And I think there are pluses and minuses to that. And I'll talk more about some of the concerns about that. But I think there is an advantage there. There is data that since the pandemic started, overall patient satisfaction has been high with video visits. I've listed some resources here at the bottom, some references that I won't go through in detail, but it has been published that overall patient satisfaction is high. That said, I don't think every patient or every person wants video visits. I would argue that those who want it, again, should have equitable access and opportunity for it, but I don't think we can assume that every patient wants video visits, and I am very glad we'll be hearing a community perspective today. It has been documented that video visits can be lower cost to patients. And again, I would refer you to some of the resources at the bottom. The link at the bottom to the COVID-19 Healthcare Coalition Telehealth Impact Survey, I think is very interesting. They have surveyed providers and patients about their experience. And one of the most poignant questions they asked patients was, if it weren't for telehealth, meaning video or phone visits since the pandemic, what would you have done for care? And the most frequent answers were delay care, have a face-to-face visit, self-treat, or go to the emergency department. So again, I think there are a lot of advantages here, and I would argue that we need video visit or telemedicine as an option for when it's clinically appropriate or when it does reduce barriers and a patient wants it for the future. Now, there is a phenomenon described as the digital divide, and this really describes what Dr. Reback was saying was not everyone has access, and this is not a new idea. This idea has actually been around for years, but the literature pre-pandemic largely focused on differences in ability to access telemedicine because of age, living rurally, or being a person with disabilities. That's really where I've seen literature on the digital divide from before the pandemic. Now, since the pandemic started, there has been increased recognition, I would say, for how this impacts patients across healthcare and how those individuals who have been socially and economically disadvantaged or marginalized and have disparities or disproportionately high rates of all sorts of healthcare outcomes like COVID-19 illness also have disproportionately high barriers to accessing video visits. And this has been recognized by a number of authors. And so I'm going to focus more now on the digital divide and the sources of this divide before we talk about and get into a discussion of what we together can do about it. Now, there are a lot of needs for video visits, and some of these I don't think are talked about as often as perhaps they should be. Clearly, one needs a device. One also needs a device with sufficient data and reliable broadband. And I'm imagining many of you can identify with this. I certainly have had visits with patients who have a device in hand and are trying to get on video, but they don't have enough data or the video freezes and we just can't make it work. And the issue is not lack of a device. A person also needs to have a degree of technical literacy or comfort There absolutely are language barriers utilizing a lot of video visit platforms. Privacy also, I think, is a very important requirement, or it's optimal for doing a video visit. I certainly have connected with patients from a common area of the shelter where they live, patients walking around downtown because they wanted to get out of their shelter, patients huddled in the corner of a parking garage because they didn't want to do a video visit at work. I think privacy is a key factor that we need to consider, and also a big one for our patients and clients. Social support, I think, is a big difference for the person who has family and friends to help them get on a video visit than those who are socially isolated and don't. Now, this digital divide is not unique to healthcare, and I think could just as easily be described for education and other access issues. The photo at the bottom right made headlines because these were two young women who were sitting outside of a fast food restaurant accessing the Wi-Fi so they could do their schoolwork. Again, the issue was not lack of a device, it was lack of stable broadband. This made headlines, and the issue was solved by giving the family a Wi-Fi hotspot. So again, I think we need to consider all of these aspects. Stable broadband access has been described as a social determinant of health, or has been proposed as a social determinant of health. And I think that that is important to remember. When we look at barriers to accessing video visits, a lot of things come to light. You can see here on the left, around 20% of individuals in the US still don't have a smartphone. And on the right, somewhere between 25 and 30% of individuals don't have reliable broadband. When comparing by various social determinants of health, such as age, race, education, income, or location of residence, you can see disparities. This is information from Jorge Rodriguez, who has really been a leader in research and thought in this field. This is in the few years before the pandemic, and then I'll turn to some data from the pandemic. This was a study in which 85,000 residents of California were surveyed, either by calling their landline or cell phone, and asked about their use of telehealth, again, telehealth being a video or phone visit. And several factors were shown to be independent predictors of being able to connect by telehealth. And you can see, I have lumped them here. The authors did not lump them, but I have lumped them here. You can see the factors that indicated less likelihood of using telehealth, including limited English proficiency, Medicaid insurance or being uninsured, lack of usual supportive care, or living in a non-metropolitan region. And I lump this here because the other thing this brings to mind is my patients who would fit several of these categories, and the intersectionality, if you will, of having several of these elements of socioeconomic disadvantage that will probably contribute to barriers to accessing both video visits and virtual healthcare of any form, including use of the electronic patient portals. There is data from during the pandemic that these factors are creating barriers to use of telehealth and telemedicine. For example, groups from University of Pennsylvania have looked at their primary care and subspecialty outpatient visits, and you can see here factors that were found to independently predict lower likelihood of use of any telehealth, including older age, being of Asian descent or having limited English proficiency, and less likelihood of video visits use, specifically older age, which was defined in the study as older than 60, female, Black, Latinx, or lower income, which was defined as below $50,000 per year. And you can see below that data from the same group found lower likelihood of use of online portals. And I keep bringing that up because I think it's notable, because use of that portal does allow one to communicate with their provider, communicate with their healthcare team, request refills, and really address issues much more rapidly than waiting for a visit. Additional data from our Ryan White HIV clinic here, not yet published. When we compared which factors were associated with use of video visits, we found similar results. For us, age above 50 was associated with lower likelihood of using a video visit, as was Black race compared to white race, Medicaid insurance compared to other insurance, and notably, having ever logged into our patient portal predicted use of a video visit. So we see that as a marker that someone is ready and has access and can do a video visit. And I'll come back to why I think that's important and where it can contribute to QI interventions and improving access. Now, before I talk about the opportunities and the way forward and how I'd like to see us as a community improve this situation, I want to acknowledge some other risks of telehealth that I think are important to discuss. And again, I would appreciate all perspectives on this and your comments when we have time. So absolutely, as we expand use of telehealth and telemedicine, there is a risk of worsening these disparities in access, that these barriers to use of video visits. I think less described, or maybe not less described, but less considered risks include exacerbating implicit biases. I think even just me discussing these factors carries some risk that we need to acknowledge. And what we never want to do is see a patient and presume because they are homeless or because they are a certain race or ethnicity or because they are older that they can't get on video. And I fear that that happens to some degree, that individuals see someone who's older and say, oh, they can't get on video, I'm not even going to offer it. We absolutely do not want that to happen. And I think we need to acknowledge that risk, but I think it's important for us to discuss this so that we can reduce the barriers and help everyone be able to stay engaged in care. Concern has been raised that video visits or any sort of distance visit may lead to less personal care and less rapport or trust. I'd be curious your perspective. For me, I have found that the patients I've known for a while who now connect on video, I don't feel like that's happening. I feel like we have some established rapport and the video visit doesn't detract from that at all. I do feel this with new patients though, and I do hesitate to do distance visits for new patients because I do want to establish that relationship. But sometimes, again, the benefit of a distance visit may outweigh the risk. I think there's concern about reduced quality of clinical care because it is such a limited physical exam by video. And again, I consider when offering video visits what kind of physical exam I need. And I would not argue that video visits should replace all of our in-person encounters. One thing that absolutely has come up for me when doing distance visits during the pandemic is the challenge coordinating labs. And I do not think we have an easy solution to that, but I think that is another important consideration. If I'm going to see this person by distance, how are we going to coordinate the labs? Is there somewhere closer to their home? Is there another way to do it? And then finally, and I guess this is the one that I think hasn't been considered enough, the added administrative burden. Video visits can reduce a lot of burden and barriers for the patient. We certainly have experienced added burden on us trying to get the person set up ahead of time, testing their visit, making sure that the visit is going to be successful. And I'll come back to some strategies for how to do that. So those are what I see as the risks of this sort of burgeoning era of telemedicine. But I really want to stress that this could be an opportunity. And if we work together and bring all the key players together, we can make this an opportunity to reduce the barriers and to improve access to care and engagement in care. Several authors, including myself, have written about this opportunity. And I think there is growing recognition that we need to work together to do this. So what I'm going to turn to now is some of the ideas for how we turn this into an opportunity, reduce the barriers, and improve telehealth access for all. First, from the standpoint of advocacy and policy, I think we need commitment at all levels to expand access to devices and broadband. So this is commitment at the federal level, the state level, healthcare systems, and community-based organizations. I think we need, again, at all levels, funding and reimbursement, and that funding and reimbursement really should align with equity, and a goal needs to be equitable access. There needs to be a commitment to developing telehealth infrastructure, promoting technical literacy, and creating reimbursement models that will fit with this era of virtual healthcare. I would argue and have advocated at the federal level that we need to extend the emergency waivers, those waivers that allow payment equity for video visits and reimbursement for phone visits. As I showed you, phone visits have been a critical method for individuals to stay engaged with care. There also have been waivers that facilitate telemedicine treatment across state lines, and a number of those waivers are starting to end. And I think that is something that should be looked at for the future as well. And overall, I think we need partnership with industry, partnership with tech, and a coming together of all the key stakeholders, providers, patients, community-based organizations, public and private healthcare leaders, and frankly, more conferences like this to discuss this issue, to identify the barriers, and to work together to address them. I think this is also an opportunity for research to quantify the issue and then identify the pinch points and hurdles and the best methods to reduce barriers. I think we need to understand patient preferences and needs. Again, not all patients want telemedicine, but those who do, I feel strongly should have equitable access to it and opportunity for it. Here locally, we are trying to get more input through surveys of our patients, focus groups, and working closely with our community-based organizations. I think this is an opportunity to use research to quantify telemedicine usage and the barriers, to study implementation solutions, and also to better understand implicit biases from the provider perspective and acknowledge them, address them. And there are researchers working on this. And I'm very thankful that there are researchers looking at how do implicit biases manifest themselves if I do a video visit with a person of one race compared to another, or if I do a video visit and a person has a mansion in the background versus a shelter location in the background. I think we really need to better understand that. There are a number of clinical and QI interventions, and this is not an exhaustive list, and I would love to hear what you have seen be successful locally. But I think we need to standardize telemedicine checklists. And what I mean by that, again, is never assume a person will or will not be able to join by video. I think we need to go through it in a systematic way with every single patient and test the visits ahead of time. And I'll show you an example of a checklist. Sometimes giving a device is what is needed to solve the problem, but often it is not enough. The device needs to have data, or more often I find individuals need Wi-Fi hotspots or other ways to make sure they have stable broadband. And giving headphones can be a really big step towards added privacy. Telemedicine stations at accessible locations. For example, we have worked with local case management groups to set up spots at their offices where individuals can come and do their video visit. They can get help and support and have a private location. I find that often they may not be connecting with me that way because my clinic isn't that far from them, but they might be connecting with their behavioral health provider who's hard to get to, or a specialist who's farther away. We also have a pilot working with the local library system to create telemedicine stations at a variety of library locations. A group of really motivated medical students here helped set up a telehealth training kiosk at the medical center where patients could go and get help and support. I also think we need more funding and support for telehealth navigators or telehealth interpreters to help people get on. At all levels, including the tech and the clinical process, I think we need the ability to rapidly integrate interpreters, including sign language interpreters, into video visits. There also are well-described other accommodations that are very important for individuals with disabilities, and I've given you references here. For time, I'm not going to go through all of them. Absolutely, when we give individuals instructions to log on to their video visit, I think they need instructions in multiple languages via simple platforms, including SMS, not only through the electronic health record. I also have learned to always start video visits with check-ins about privacy and a discussion and consent from the patient, and a question about, well, who else is present? Because I have learned from experience that sometimes there are other people off screen that I'm not aware of. And importantly, I think telehealth usage and gaps should be key performance indicators in healthcare. And those performance indicators, again, should align with equity. Here is a sample checklist that can be used and goes through not only language needs, software and hardware needs, but also where the patient will connect from and what other assistance they need. So to conclude, this is a phrase that a colleague taught me and that I really appreciate. Telehealth is public health and vice versa. And so I would argue that as a community, we need to consider telehealth access as a social determinant of health, commit to promoting digital inclusion, and work together to acknowledge the digital divide, acknowledge the risks of telehealth and telemedicine, and as we are doing today, come together to have a dialogue about it, share perspective, and brainstorm solutions. I will stop there, and if there's a couple minutes, happy to field questions or comments, and would love to hear your perspective.
Ryan, thank you so much. That was a real tour de force, I think was very thought-provoking. I know for me, and I have gotten a couple of text messages from people who found it similarly thought-provoking. So I haven't seen any questions come through the chat yet. I do want to encourage people. We do have a minute or two for a few questions for Brian before we move to our next agenda item for the conference. And while people are thinking of that, Brian, can I just ask you, thanks for reiterating your assertion that that broadband access may be a really critical social determinant of health already and going forward, and was just trying to think and wondering what your perspective is on what role policymakers and payers are going to have in reimbursing particularly safety net providers for this kind of work, which is really going to be requisite to this having investments at the health system level. Any insights into that?
Such an important question, Rafi. Thank you. A couple of thoughts to share that I hope also will stimulate discussion. So one thing from a policy level is a lot of those waivers that have allowed us to implement telemedicine are not planned to be permanent. In fact, they are tentatively to end July 20th. That said, the Department of Health and Human Services has written a letter and sent it to the governors of all the states and expressed a commitment to extend them through 2021. But from a policy level, I think we need advocacy to continue reimbursement, again, for video and phone visits. And I think that's incredibly important. To the other piece of your question, Rafi, in terms of funding, is I think we need both recognition for this and funding at all levels. And what I mean by that, for example, is helping programs to help people not only get devices, but also get broadband, as you said. For example, there's a great program where the VA paired with Apple to give patients devices with data plans. Again, the with data plan is absolutely key. So we need recognition of that need of broadband as a social determinant of health, funding and support at all levels to help eliminate that as a barrier.
Yeah, thank you, Brian. I couldn't agree more. I know in a research context, when we've tried to give people who didn't have devices access, through giving them a device, it had to come with built-in service, or the whole thing was essentially a non-starter. Couldn't agree more. I personally have like 7 or 8 other things I want to talk to you about, but we don't have time. We did have one request in the chat. If you would be willing to share your telehealth checklist, because someone was really interested in it and didn't get to screenshot it when you put it up. I don't know if you're going to be willing to make your whole slide set available. I know we actually had a request for that also, but thanks so much. Those are really beautiful, beautiful conceptualizations. Do you think that'll be possible?
Happy to do both.
Great. Thank you, Brian. Okay. With that, Dami is going to probably scream at me because we're 2 minutes over and, we have a very tight schedule. So with that, we will thank Brian very much for that wonderful talk. And Dami, I'm going to hand the program over to you for our raffle.
Great. Thank you again for that great talk, Dr. Wood. I'm going to go ahead and do the raffle. So how this works, I put a comment in the chat so you can read that as well, but I will be shuffling the names of people who registered. So only those who are in attendance can actually get to win. The prize is a $25 Amazon gift card for anybody whose name pops up on the screen. So I'm going to do a random name picker. I will share my screen right now. And I'll be showing this random name picker, and just so that we're clear, everybody's name is actually on here. So if you registered, even up until this morning, your name is on here. And I'll go ahead and pick a random name. If this is your name, please indicate in the chat to everyone so that we know that you're here, and just say, I'm here. And then send me a message with your email so that I can reach out to you with the Amazon gift card code. It's going to be an electronic gift card. All right. Drum roll. Elizabeth Pacheco. Are you here? I'm going to give a few seconds for you to send. You can just say a quick here. And then, all right, I think I'm going to move on. Oh, I see something in the chat. Oh, that's a comment for Dr. Wood. Okay, I'm going to go to the next person real quick. Barry Z. You here? Barry?
I see Barry's name in the participant list. He's here.
Perfect. Yay. Okay, please send me an email with your message with your email. All right, the next person, we're going to do 2, is Faria J. I hope I said that right. I apologize if I did not pronounce your name correctly. I see another message in the chat. Okay, perfect. So those are 2 winners. And then we'll have 2 more chances, or at least 4 more to win. Thank you. On to you, Dr. Reback. Dr. Landovitz.
Dr. Landovitz.
Okay, great. So I hope that was as much fun for everyone as it was for me. Just so we're clear, and in case you missed this, the whole idea is the longer you stay with us in this conference, the more chances you have to win. Get it? So like after our break, there's one that's strategic. And at the very end, there's another one. Again, strategic, not our first rodeo. So we're hoping that you'll stay with us for the science and the conversation and the discussion, but we know that prizes talk. So we hope that you'll stay. Regardless, okay, we're gonna move right into our next piece of the conference, which is gonna be a panel discussion on the use of telehealth in care, both clinical and non-clinical care. And we are gonna have 3 speakers. Each speaker is going to give us a brief presentation, and then we're going to have time for a discussion with the panel that is gonna be really, I think, most interesting and most useful if you all participate. So after and as each speaker is giving their presentation, please put thoughts and comments in the chat, and hopefully we can have a robust conversation all together after each panelist has spoken. So our three panelists, I'm now going to introduce them as Dami cues up the spotlighting Zoom technology. It's really amazing how in the last 15 months, we've all learned the ins and outs of this small little program that who knew anything about before the pandemic, right? I should have bought stock in it before the pandemic. That was a missed opportunity. But anyway, our three presenters are Miguel Bujanda, who is the executive director of Reach LA. And for those of you who are outside of the LA area, Reach LA is a Los Angeles-based arts and health community-based organization that serves LGBTQ and minority youth of color. As executive director of Reach LA, he's really strengthened the organization's outreach to expand prevention services with access to PEP and PrEP services, particularly to Black and Brown community members, and the use of telehealth service for expanding free or low-cost mental health services to lower uninsured community members. So welcome, Miguel. We also have Gifty N-Team, who is a primary care physician in the UCLA system, board certified in both internal medicine and pediatrics. She practices in Santa Clarita and was previously the medical director for AIDS Project Los Angeles Health, where Dr. N-Team and I first worked together doing some PrEP demonstration projects for gay men, trans women, and cisgender women here in Los Angeles. She's an active advocate for her patients and really enjoys taking care of patients of all ages and has had extensive being forced into using telehealth for service delivery during the pandemic. So welcome, Dr. N-Team. And finally, and last but not least, we have Dr. Dave Solomon, who works at Venice Family Clinic here in the UCLA health system and does a lot of primary care, HIV care, and working with persons experiencing homelessness and substance dependence disorders, and has some really unique and fascinating experience delivering substance use and mental health services through telehealth, and is going to be sharing some of those experiences with us today. So thanks so much for joining, Dr. Solomon, as well. So we're going to begin with Miguel. And Miguel, the floor is yours. Again, thanks for joining.
Thank you very much for having me. I really appreciate it. Hi, everybody. My name is Miguel Bujanda. I'm the executive director of Reach LA. I want to just take the opportunity to thank the organizing committee, everybody for just having me on. It's been a great pleasure to work on with this project. And more importantly, I am glad to be part of the organizations that are really utilizing telehealth for PrEP services. For those who don't know, as the executive director of Reach LA is a community-based organization. It was founded in 1992. Historically, this organization was focused on art programming for youth in the Southeast downtown area. So we evolved in the early 2000s and began primarily focusing on HIV prevention work for MSM, women at sexual risk, and transgender women, all while still focusing on arts and social networks of these vulnerable populations. So I've had the honor of serving as executive director since 2017. And not only am I part of the community that we serve, I grew up using these services. I grew up using community-based organizations. I started my histories working with Bienestar when I first, in 1997, I was 19 years old as a young person. And now, working at different organizations, APLA, even UCLA, throughout my years. And I had the opportunity now, the honor of serving as executive director. I share this because it's no longer 1997, and prevention programs have evolved. And not only are we utilizing from harm reduction programs to condom distribution, now we're using biomedical prevention methods to really provide services for these vulnerable populations. And Reach LA has been grassroots since the beginning, and we are a non-clinical CBO here in Los Angeles. So one of the praises that we get from community is that we are not a CBO, that we are not a clinic, and we have more personalized programs for young people. We're more grassroots. And however, we also knew that being a clinic also had its challenges because we were unable to provide this new innovative way to prevent HIV, which is biomedical. So this is when we decided to explore new options, and to expand our reach, no pun intended, to better serve our community. So ideally, I wanted to make sure that everybody knew that, we had barriers of how to access PrEP services for our community. All we had to depend on our community partners to send them to these other services. However, being a non-clinic, we didn't have any clinic space. We only do HIV testing. We don't even do STI testing here. We now have partnerships with that, but we didn't necessarily have the capacity to provide PrEP services. So we had limited medical infrastructure. We didn't have protocols, EHRs. We had a low uptake of PrEP among our population because they couldn't get it from this grassroots organization. So, how did we as a CBO actually provide, a non-clinical CBO provide PrEP services? So we had to find partners. We had to find people that could actually work and adapt and tailor their programs to work with us because we're so limited in the way we can actually provide the services. So we needed a partner that provided utilizing PrEP appointments on video calls, contract with a home testing laboratory that provides HIV testing, STI testing, of course, other kidney function screenings that are vital for PrEP appointments, and partner with a pharmacy that provided mail-at-home prescriptions. Now, think about this. A lot of us talk about telehealth, but what aspects are telehealth? Is the pharmacy telehealth? Is the laboratory telehealth? Or one of the advantages we had was everything in this model was at home. They never had to step out of the house to get the service. So I want to show you that our telehealth process. This is kind of like how we modeled it, how ReachLA was working with partners. We would actually do the recruitment or be part of the recruitment process of the service. And eventually we would connect them with our telehealth partners that would actually provide the doctor's visits and, more importantly, discuss to them if PrEP was right for them. We initially did a screening to make sure that they're at risk. They could have tested here on site, and we could have referred them and signed them up here at the center through our own personal use of Wi-Fi and so forth. But would support in the enrollment process and making sure that they understood everything that was going on. So they had a Reach staff member participate in every step of the way. So once they did the home testing kit, we provided STI results, and if they were positive, refer them to services, whatever the area was. It may not have been us, it may have been something we already do, is partner and send them to our community partners. The provider would have a virtual medical appointment with them. The pharmacy would then distribute the medicine and send it to them. And then we would provide 3-month follow-up to making sure that they got their new testing kits. They would be able to do the testing kit, and they're able to make sure that they're able to meet with their provider. So ReachLA participated in every step of the way to make sure that they were hitting all the vital points, and of course, checking on their adherence. Some of the benefits to having a telehealth program for us was client satisfaction. I think we mentioned this in Dr. Brian Wood was mentioning in regards to the satisfaction. People were like, oh, this is easy. But we never marketed it necessarily as a telehealth program. We offered it as free PrEP services. That's what our community understood that, because they're like, you're not a clinic. What are you? We said, oh, we got free PrEP services, make it as comfort and easy from the comfort of your own home. And that's how we market it. There's no in-person services. They never had. We have over 1,000 patients signed up on PrEP. A lot of them have not physically been in our space because we cater to them around the area. It reduces barriers to care. We're able to track adherence because we're checking in with them every 3 months, see how they're doing. And we actually get to follow up and see if they're refilling the prescriptions. And those who fall out of the care, we check in on them and try to get them signed back onto the program. And increased our capacity. We now have an EHR. We understand we have protocols in place to work with clients on telehealth services. And we've had really great partnerships with individuals that really have increased our personal capacity as an organization. So some of the recruitment tactics was really just providing the best customer service possible to our clients. We utilize social media campaigns, utilize social networks recruiting. So a lot of word of mouth from our clients that came in and signed up. they would actually sign up for our program. And we had prep navigators that would actually follow up and ensure that they were maintaining the services through our partners. So just a little data so you could see in 2020 in the midst of the pandemic. Now, mind you, just a little history also, we started this just before the pandemic. So we did not know the pandemic was going on, right? We started in November of 2019, the process of getting everything organized. We hit the ground running in January 2020, and then the pandemic hit. We had a 300% increase of requests for this service. It was a coincidence, but at the same time, a welcome one in the sense that so many people that didn't want to go to their doctors changed their services and went to us because of the convenience of having a telehealth services. As you can see, servicing the Los Angeles area, we've had about 606 right now. Currently in June 2021, we have almost 1,200 enrolled and regularly prescribed in PrEP services through our telehealth partners. As you can see in 2020, the timeline, in the beginning, we just had a little under 100 patients. Now we have somewhere in the 600s. That was at the end of December. But the pandemic didn't stop in December, right? So people still wanted to jump into the services afterwards. And they saw the convenience. They felt they were a little concerned. They're like, is this really going to be free? But that's part of our model here at Reach LA is building connection and trust within the community. They trusted our word. We weren't a clinic. We were trying to sell services. That's what they will tell us. And we're like, okay, well, if you say so. So it was really helpful for us to not be a clinic. That was one of our advantages. Racial differences, we primarily recruited 49% Latinos, Black, African American, white, and Asian Pacific Islanders. Our target is Black and brown folk, but we're not going to turn away anybody who needs the services. So some of the lessons learned. So if a CBO is interested in doing something like this, there's a lot of things that you need to take in consideration. Develop strong partnerships with walk-in services, with in-person services. There's some clients that do not want to do telehealth. I still need to refer them to y'all to provide those services. Establish a strong remote linkage to care program. So they may not be in your direct vicinity. So you need to have a referral system that is out in Palm Springs. I'm in Los Angeles, so I had people in Palm Springs, Orange County. They're not my, direct vicinity, but I needed to make sure that they were able to be connected to the services in a timely manner. Increase treatment referral programs for non-local residents, making sure that we invested in an EHR that actually works for you. We're not a doctor's office, so these fancy EHRs were not necessary. But also the free ones don't work really well, so don't do that. Invest in something that works for you. And request training for motivational interviewing and other rapport building skills, making sure that your client is able to manage people, because here at Reach LA, we're so used to face-to-face. I had to increase the capacity of the staff to be able to work over the phone. And seek funding for an in-house STI treatment. Because they may tested positive, maybe they wanted to seek services from us. And we didn't have that. And we're still working on that to ensure that we provide the best services possible. So that's a little snapshot of what Reach LA is. As you can see, this is my contact information. As you can see, some of the pictures behind is the new renovated space. We are reopening, and I invite you all to our open house on July 24th from 2 to 5 p.m. here at Reach LA. So hopefully you guys can make it. So thank you very much for your time.
Thank you, Miguel. That was great. And, really, I think reminds us all how important that for certain health services like PrEP, sort of demedicalization and moving it to non-medical spaces is going to be really important for acceptability. And it's going to be interesting to see which services are going to be appropriate for that sort of non-medicalization and how we sort of best do one-stop shopping for all the components of those services. So thank you for that. I'm sure we're going to have a lot of brisk discussion when we get to the panel piece. So thank you so much. We're going to move to Dr. Inteam for her presentation now. So Gifty, I'm going to turn it over to you. Thank you so much for joining us.
Hey, thank you. I'm happy to be here. And my presentation is not, as comprehensive as Miguel, but I'm sure that we'll have a lot to talk about. So I wanted to just start off by giving you an overview of our practice. So as Dr. Landowitz mentioned, our practice is in Santa Clarita. We're UCLA primary care practice, where I work with 4 other physicians. 2 of them, like myself, are internal medicine and pediatrics trained, and we have 2 internists. And then we also have, we're a site for our primary care residents who are, internal medicine residents training with a focus in primary care. So there was a lot going on with regards to trying to, think a little bit more about how do we deliver telehealth for our patients. Next slide. But, I thought this code actually captures, pretty much what happened with us, because prior to March, there were maybe a handful of physicians in the Department of Medicine who were, providing telehealth to patients, and when I mention telehealth, I'm actually going beyond, I'm talking of going beyond in-basket management, responding to patients' messages, and actually providing medical care by video or via telephone. So come March, after emergency waivers were put into place, we ended up having to figure out how do we see our patients and keep ourselves safe, keep other patients who needed to come in safe. And so we had to, basically, as a health system, be, innovative in terms of, developing new workflows around switching visits from in-person to telephone visits or to video visits, and then also figuring out how we provide support to our patients who hadn't done this before, as well as also trying to figure out how do we even bill for these services. So there was a lot going on. And in the midst of all that, we also had to figure out how do we teach our residents how to do this? And, at what point in training do we actually, does it make sense to introduce, telehealth? Does it make sense to introduce telehealth to an intern who's never seen a patient, and maybe doesn't have a good understanding of, what a sick patient looks like versus well, when they should be worried versus not. So there was a lot of discussion that was going on. Next slide, please. But, we, emerged okay, and I'd like to share with you some challenges and barriers that we had. So, as had been mentioned earlier by Dr. Wood, we did have some challenges on, both patient side as well as physician side and the clinic side. So for our patients, even though there, some of our elderly patients who are very technology savvy, what we did notice with a lot of the patients that we're seeing up in Santa Clarita was that our elderly patients actually felt more comfortable using a Zoom platform as opposed to doing their telephone or video visits through MyChat. So, with telephone visits, we're limited because you can't see a patient, and we're actually trying to, as much as possible, have, be able to provide care to patients where we could at least, see them and get a sense of what was going on. And I'll talk to you also about some of the challenges around, having to think about doing physical exams, using a video platform. But we had to figure out how do we support our patients so that, we're actually able to provide them this care, particularly the patients who were, willing to, try it. And from my experience, I found that presenting a platform that patients had already, used, because lots of things were happening on Zoom. So some of our elderly patients felt comfortable using Zoom, but then for whatever reason had a mental block when it came to doing a video visit using the, EPIC, electronic medical record that we have. As has also been mentioned, earlier, access to reliable broadband is, an issue for a lot of our patients. And, we found that, for patients who had, challenges, we had to switch a lot of video visits to telephone visits. And, in a telephone visit, depending on what your patient is coming to see you for, you're not able to assess, and see, well, does your patient look, comfortable? Are there certain concerns that you have based on, their, appearance, as you're inspecting? There's also, challenges, and this is more so talking about around November, December, January of, lots of patients just having Zoom fatigue and just not showing up, for video visits. At the beginning, most people were home. There was, I think people had to put, some of that nervous energy to good use. And so lots of people who made appointments were actually keeping it. But we actually found that, around November, December, January, interestingly enough, when there was, we're going through the third surge, people were just having Zoom fatigue and just, not showing up for video visits. And then, as has been mentioned earlier, there's a privacy concerns also, whilst being able to provide, telehealth visits, particularly video, in our case is very convenient for a lot of our patients. For some patients, it's not, an option for them, because they might not have, places where, they can speak privately or, feel comfortable discussing, certain things, so that's something that we had to keep in mind. And then also, obviously keeping in mind some of the regulatory issues, having patients who had traveled out of state, wanting to be seen, and how do we sort of navigate that? And we had patients who had completely decided to move from California to another state, but still wanted us to, take care of them. And on the clinician side, we obviously had to learn things on the fly. So there was the issue with comfort with the EMR, talked about developing new workflows. And as has been mentioned earlier, there was a big, burden on our admin staff. We had to use them to actually call our patients, remind them of visits, walk them through how to actually set up video visits. Already talked about, no-shows and, limited physical exams. We also concerned about maybe over, prescribing antibiotics and, talked about, issues with reimbursement. Next slide, please. What I found is that, telehealth is here to stay, and it's actually a big convenience for our patients. And so, as has been mentioned before, for the patients who want it, we should be able to have the ability to actually provide this as, a way of, helping, meet our patients' needs. And then also, the opportunities for us to work a little bit more around, safety, of patients and staff, not having sick patients come in if they don't need to, being able to, offer them, care that is not compromised, from their home, and then also keep us all safe. And then also there's the unintended benefit of doing a virtual home visit, which for me was very eye-opening, just, anecdotally, just seeing patients who were always, late for their appointments. And then you see them in their home and you see all the things they have to juggle whilst having a video visit with you. And it's like, oh, wow, I understand why you don't make your appointments on time. And, as has been mentioned earlier, it's important for us to maybe think about investing in, appropriate infrastructure, and then also doing some advocacy, as well as on the physician end, developing some best practices around delivering telehealth. So with that, I'm going to stop there. Thank you.
Thank you so much, Gifty. It's so helpful to hear the perspectives of someone who was literally thrown from the frying pan into the fire, when the pandemic hit, with a large clinical practice, to figure out how you're going to continue that care. And I think those of us who do some clinical care experience that to some extent more than others. And I just want to say, when you said Zoom fatigue, I think we all immediately related to that. But we'll talk about this when we get to the panel. But someone once told me, and I haven't really looked into this, that there's extensive literature on the neurobiology of Zoom and how you're not really looking at someone in the eyes and the fatigue that that causes and the miscommunication that that can result in. And I think that's something that maybe we can also delve into a little bit in the panel. But thank you for that great insight, Dr. Intine. We're now going to move on to our final presentation of the panel, and then we'll open it up for discussion. Dave Solomon from Venice Family Clinic. Dave, again, thanks so much for joining in your busy day, and welcome.
Thank you so much. It's really an honor to speak and to be here today. Next slide, please. So just a quick kind of overview prior to the COVID-19 pandemic. So I'm at Venice Family Clinic, which is a federally qualified health center on the west side of LA. And prior to the COVID-19 pandemic, we were doing some telehealth services. We have a diabetes care team that has diabetic educators and does some dietary counseling and works with patients longitudinally. So we were doing that. And then we had been piloting some Hep C treatment visits for patients with clinicians, physicians, nurse practitioners, and PAs. And we weren't able to bill for that, but we were kind of trying to do that. And then we've been doing health ed via telehealth for a long time. So that's for prediabetes and high blood pressure and dietary counseling. Of course, the obvious barrier was lack of reimbursement. Next slide, please. So in March 2020, we basically switched over to essentially, I guess, all phone and video visits. Our video visits started in about May of 2020, and then I started doing group visits on Zoom for our medication-assisted treatment in approximately September. And then also during the pandemic, we were doing, or even early, we were doing some in-person outside appointments, and we were seeing patients at some of the Project Roomkey sites, which were these areas where patients experiencing homelessness went and got shelter during the pandemic. And of course, lots and lots of telephone appointments. Next slide, please. So some of the successes, in my opinion, the feedback that I got from patients was obviously it was really easy to do telephone visits. They saved a lot on gas money. And even though we're on the west side of LA, we have lots of patients that come from South LA, they come from the South Bay, they come from the Valley, and that's obviously a burden for them to do all that driving. And then of course, during the pandemic, we were able to get people off of buses and trains and public transit, and they were able to stay at home or wherever they were staying to have telephone visits with us. And then of course, for me, there was more flexibility. I could do a telephone visit at home. I could do after hours visits. If somebody no-showed, I could call them later and sort of do like asynchronous visits and catch up with them later. And then I did find that telephone visits were fairly efficient. And both of those, I think, increased our access. And of course, geographic reach was increased for patients throughout LA County. Next slide, please. So in terms of communication, I felt like for the most part, I was able to communicate well with patients. And I think what Dr. Wood had mentioned about, it's really nice to have an initial visit in person. And I was mostly doing care for patients that were already my continuity patients. And I did have a few patients that I did have patients that I met during the pandemic over the phone and before I saw them in person, but that was more of the exception. And then of course, giving diagnoses like a cancer diagnosis is obviously something that I would just not want to do over video or phone if at all possible. Musculoskeletal and neurologic conditions, I think, lend themselves to in-person visits for the most part. The feedback I got from patients was that they really appreciated a combo of in-person and telehealth, and that some of my patients who are elderly also really valued telephone visits. And then patients made use of their wait time. They, like I had patients working on their car while they were waiting for me, or getting groceries, or doing all of those other things that would otherwise have been, all that time would have been lost sort of just sitting in the waiting room. Next slide, please. One thing I wanted to mention when Dr. Landovitz introduced me, I do see patients for PrEP, but I don't treat patients with HIV, although we do have physicians in our clinic that do that. So any of my patients who have HIV, they're also going to see one of the other docs. But I am doing PrEP and, of course, doing medication-assisted treatment for people dependent on opiates. So some of the challenges, I did find that after a while, some patients just didn't want to come in for regular appointments. And so enticing them back in so we can have an in-person visit was sometimes a challenge. Video visits really didn't achieve their potential, I think, for me. And I thought that phone visits were really the rock star of the pandemic, for me at least. I had a ton of trouble with dropped connections and technical issues and glitches, and actually I just checked with our front desk right now, and basically when a patient calls to make an appointment, we offer them in person or a telehealth visit, a telemedicine visit, and so every single patient is offered a video visit, and patients really have been voting with their feet. And I looked back over my patients seen in the last 2 months, and in June, I have had 1 video visit, and in May, I had 3 video visits for a single person, not including group visits, but just for single patient visits. And everything else has been telephone visits in terms of the visits I'm doing via telemedicine. So I think, of course, there are some barriers in terms of like not having access in broadband and video, but patients are also choosing phone visits. So lab draws, we've always had drop-in lab draws, so that wasn't really an issue for us during the pandemic. And then I'm just sort of paraphrasing Yogi Berra, but the physical exam is important when it's important. So, of course, there have been a number of times when I've had to bring patients in for regular in-person visits. Next slide, please. So we got our health ed department to purchase a whole bunch of BP monitors, and we were either having patients pick those up in the clinic or we would mail them to patients wherever they were living. And so that allowed us to get blood pressure for telephone visits, which was super, super important and helpful. And then we were doing medication delivery as well for patients at Project Roomkey, and as well as any of our patients that desired that. Next slide, please. So medication-assisted therapy, basically the frequency of appointments didn't really change from prior to the pandemic to during the pandemic. And I was doing group visits with a counselor and a case manager for medication-assisted therapy for Suboxone specifically. And our show rate was pretty high prior to the pandemic. But these group visits gave people social support, they built a sense of community, and it was a wonderful opportunity for peer-to-peer mentoring and teaching. Next slide, please. So after the pandemic, we started group video visits on Zoom, and we've really struggled to get back to the numbers that we had before. And when I reached out to the case managers, they said there are some technical barriers with patients not having video access. And also they said, a lot of patients have said that just sort of being on Zoom, they just didn't get the same benefit that they did prior having in-person visits. And then our case management for medication-assisted therapy has been really robust over the phone, as well as counseling with the social LCSWs. Getting urine drug screens has been a real challenge. It's not required, but we do try to do a couple of those at least a year. And prior to the pandemic, we were doing them at every visit, and that helped us to understand, who is, monitor adherence and figure out, who's struggling with that. Next slide, please. So here's some data that I found. I haven't found anything more recent, but you can see that basically accidental drug overdose deaths spiked here in April during the shutdown, and then dropped after that. And I think the credit goes to the telephone visits and video visits. You can see that's a pretty steady trend throughout the different areas in the LA County. Next slide, please. So here's this is like not published or anything, but I just basically got some data for our no-show rate, and you can see that this is for patients experiencing homelessness. Our no-show rate for phone visits was staggeringly low. It was like 4 to 5% versus videos. It was, we were doing very few videos, but it was up in the 30% range. And then of course, for in-person visits, our pre-pandemic no-show rate was around 20%, and then currently it's around 30%. So you can see how profound this access was for our patients experiencing homelessness. And that, I just had, I was able to do phone visits for just about everybody in terms of my patients experiencing homelessness, as well as my patients taking Suboxone. Next slide, please. So yeah, phone visits are, for me, phone visits, again, I would just reemphasize that that phone visits were really the rock star of the telephone visits were of the rock star of the pandemic, and they were simple, and they really improved access for all of our patients, especially our most vulnerable patients. Okay, next slide. I think that might be it. Yes, thank you very much.
Thanks so much, Dave. Super interesting. I think you've sort of highlighted some of the real challenges of sort of groups in general in the Zoom setting. The ability to create community is challenging, and it just doesn't work for some people, does it? So let me sort of throw a conversation starter out to the panel and ask our participants in the audience to please think what questions or comments they have and to pop them in the chat. We have about 8 minutes for discussion before we take a break. And those were 3 really different perspectives, but all really interesting and thought-provoking. And I'm wondering, one thing that was, I think we're hearing commonly is there are certain things that telehealth or remote visits, particularly Dave, I heard you say, I think 3 times the word rock star for telephone visits. And that was really sort of notable to me that for your patients, telephones seem to work better. But there's some things that in-person or activities, for lack of a better word, we haven't yet found creative solutions for how to make everything completely remote, right? You talked about that home blood pressure monitoring was a savior in some cases, but I'm willing to bet that for some people, them not being able to access it or not wanting to access that would be a limitation for the management of that. And Miguel, you talked about wanting to provide in-house STI treatment so that people would have one-stop shopping. But when you go to a completely remote model, even if you can do remote testing, being able to provide that treatment when someone won't come to a physical location becomes really challenging, doesn't it? And Gifty, I'm sure you were sort of very focused on some things that an exam you need to see, and I think everybody sort of acknowledged that. Dave quoted Yogi Berra sort of in saying you need a physical exam when you need a physical exam, and I know there are going to be things that we're going to find as people do come back in person that we may have missed because of the lack of an ability to see people in person. So do you guys have thoughts on, what the future of this hybrid model is likely to be, and what things just are never going to fully fit into a completely remote model, and what the limitations of that are?
I mean, I would definitely say that I think healthcare providers, we need to listen to our patients and find out what they need. I think we're so systematic and so methodical in the way we provide services, and we have so many regulations that we have to follow. It's like we forget that the patient is a person that really needs services tailored to them. We work with a very vulnerable population, and for us to get so stuck in the minutia of all these details, these protocols, we're going to lose patients because that's not for them. So I'm not saying that what we're doing is going to work for all of us. Like I mentioned, like I still rely on our community partners to provide those in-person services. I still need to be able to refer them, just like I do when I have somebody newly positive for HIV. I need to know who to work with. It's about really adapting. So having a hybrid model is the way to go, because you have to be able to have them access both. However, we shouldn't be afraid of a client saying, I don't want to use you, and not take it personal, because it's about what they need. And that's moving them into a telehealth model. That's in person or some sort of hybrid, or maybe not even your organization. And I think a lot of people get so stuck with that sometimes. And I've learned that only because I just recently got into this, and a lot of clinics don't like telehealth because of the reimbursement rates and because of this, because of money thing. Do we really think patients want to hear that? And I don't think so. I think it's like, I just need a free service, and working with young populations, vulnerable populations. That's all I care about. It's what works best for them, and I've been a nonprofit. I'm not here for the money. We all know that. We that's what we do, right? What the thing is how do we get the best care for our services without compromising our egos? I don't know. Just something to think about.
I mean, I think to add on to what Miguel is saying, I think that definitely meeting your patient where they are is important. I think that, telehealth is here to stay. I think we need to think of how to make it better on the physician side. It's been really interesting. I think that, telehealth has actually forced us to be better history takers and to also think about, how to be creative with some of our physical exam skills. So then, for instance, how do you assess a patient who might have shortness of breath, who might be speaking to you in complete sentences? Are there some ways that you could do that, through a video platform or even on the phone, that would then tell you, maybe you should come in, I need to see you. I think that definitely, there are lots of, I think University of Minnesota actually has a whole orthopedic telehealth, guide where they have all these, all these physical exams that you can do, if you're doing a video visit on a patient from home. And, I think that was the advantage of the fact that we had to, do all these. So definitely we have to be creative. We have to meet our patients where they are. What we did actually in my practice, we see we have a clinical psychologist embedded in our practice, and we see, lots of people coming through it, just your run of the mill depression, anxiety. And so we had to figure out really quickly, how do we send over a PHQ-9 and a GAD-7, through the portal to our patients ahead of their visits. And, the PHQ-9 has the question number 9, which asks about suicidality. So then, at what point do you have to send that, and what are the risks of sending that? So I think, definitely you need to be creative with workflows and figure out, from a medical legal standpoint, what you can and cannot do. But, having the objective of meeting your patients where they are, I think, is, a good goal to keep in mind.
If I don't know when we're out of time, but
Or Dave, please go ahead.
I was just going to say that at least in my experience, probably 85% of patients can be safely seen over the phone or video. Rare is the patient who's going to come to clinic with an emergent illness, although it does happen at our homeless clinic site down in 5th and Olympic in Santa Monica, the Access Center. But so I do think the vast majority of what we're doing in primary care can be done over the phone and video. It just seems like patients are basically voting with their feet that they really, really do like telephone visits. So I think in terms of providing service for medication-assisted therapy, that is really, there's a lot of dropout and sort of patient loss to follow-up. And the phone, I think, has been a real lifeline there for folks who otherwise would just, the barriers are so high to get into clinic, but they're coming back and we're having phone visits with them, and that's keeping them connected and on a life-saving treatment.
Dave, can I just ask you said the rates of people coming in for the medication-assisted therapy groups had really fallen off and were difficult, but you're able to stay in touch with those people by phone. That's acceptable.
Yes. Yeah.
That's really interesting, right? Because I think, we worry about our most vulnerable and fragile patients and how to keep them engaged. And it sounds like it's not going to be one size fits all. Yeah. Okay. Well, we are actually out of time. I wish we had a little bit more time for a group discussion, but it looks like there's some comments coming in the chat, and we'll circulate those for everybody. And Dave and Gifty and Miguel, maybe you can add some comments in the chat. But we're going to go to a break. People probably need to grab something to eat or osmoregulate, as we like to call it in the medical field. That means pee. And we'll be back at 12:40, and we will do a raffle right when we come back. So please try to be back on time, at least if you want to be part of the raffle. And we will continue on. And thanks so much for a great first half. Please put more comments, questions, thoughts in the discussion, and our panelists will continue to engage, and we can have more ongoing conversation in the chat, even as we go to break in the second half. So thank you. Thank the three of you so much. And we'll talk to everyone in about 10 minutes. Thank you. Okay, welcome back, everyone. Hopefully you had a good 8 minutes of personal time there. We're going to go right into our second raffle, and then we will continue on with our conference. Dami?
All right, I'm gonna go ahead and start the raffle. I'm sorry, my phone is ringing in the background, so I'm gonna mute myself and just go ahead and do the raffle. All right, so this is gonna spin again, and we'll go ahead and select the name. For those who were not here at the beginning, I will select 2 names. If you do hear your name, please indicate in the chat that you're here so that we know. And then after that, send me a private message with your email address. Sam Phillips. Is Sam Phillips here? I see a chat coming in. Yes, okay, congratulations. You get a $25 Amazon e-gift card. All right, the next person. Alexa Bunton. Alexa? Going once.
Hi, I'm here. Sorry, I'm
Um,
trying to get the chat up.
All right, Alexa. Okay, go ahead and please send me a message in the chat, a private message with your email address. Okay, thank you and congratulations to you both. All right, on to you, Dr. Reback.
All right, we are going to move on to the consumer video, but I am going to give everybody an extra 2-minute break because that is scheduled for 12:45, and there's some people who are following the agenda very closely, and I don't want them to miss the consumer video. So we will come back at 12:45. And in the meantime, congratulations to all of you winners so far. We will have a third raffle at the end of the conference at 2 o'clock. All right, so I want to talk a little bit about how this video came about. We wanted to have a panel with the consumers. It was really important to those of us who were putting together this conference to hear the voice of the consumers. Years ago, when I started, I mean, I'm talking about decades ago, when I started doing my work with active substance users and meth users, and we started talking early stages of talking about needle exchange and having conferences, it was very important to us that we always heard the the voice of the consumer. And in some of those early conferences, the way we did that is I have my research center, community center in Hollywood. And the way we would do that is we would invite people to come to our center because that's where they were familiar with coming for services. And we would drive them to where the conference was happening. We're talking about 30 or so years ago. So, you know, we would have our conferences typically at convenient locations like St. Anne's, and we would drive the people who showed up because they had no other way of getting there. So when we went to the virtual format, we were trying to figure out what was the best way to hear the voice of the consumer. And we thought of inviting them to our research center, and that we would get them all together and we would put them on different screens, and staff would help them set this up. And then we would have the panel live at 12:45. But what we realized was that the likelihood of them being showing up at the exact time that we had that window was, you know, possible, but maybe not. And if we were having a live virtual conference, you know, we didn't want to hold people up or promise to have a consumer panel and have people not show up. We also questioned the ability to do that because we were right in the middle of when we were planning this kind of couple of months back. There was a heavier surge in Los Angeles County, and we had very strict procedures on meeting with people and having the 6 feet apart and setting up a computer. So we realized that that wasn't going to be the best way. And somebody came up with the idea of a video. And so that's how we proceeded, is a staff from my research center, and I acknowledge them all and recognize them. And if you're on the call, you are credited at the end of the video. They met with the participants, and they asked the series of questions that the participants then responded to. I do want to note that all of these interviews were done in the midst of COVID-19. So the participants and the staff, you don't see the staff, but the participants are wearing masks. So sometimes their responses are a bit mumbled, but this could not have been done without the staff of our Research Center Friends Community Center for being involved in the procedure. And I thank everybody for contributing to the video. And now I will turn it over to Ariki, who is going to start the video for us.
Have you received any telehealth services?
Yes, I had most of my appointments during the year 2020. Most of my appointments were all done by
We are all used to technical trials and tribulations since we've been on Zoom. So we'll give Enrique a minute or two to figure it out.
Have you received any telehealth services?
Yes, I had most of my appointments during the year 2020. Most of my appointments were all done by telehealth.
Okay.
For my prep, for my endo, everything, all except obviously blood work, but getting the results back to me for like follow-ups and stuff, all that was telehealth. All that was telehealth? It was all by video calling.
Thank you. Are you currently receiving telehealth services?
Well, I mean, I use telehealth, for my court proceeding, I had telehealth, they're discussing my issues, whereas I have a disability or not, and then the information was mailed to me, so I learned about myself and about them, there's a trust between us, what kind of disabilities I have, and if I qualify, what I qualify for. A larger amount of income or a smaller amount of income.
Please share briefly what the experience of receiving telehealth services has been for you.
It wasn't a good experience because I feel like I had a better experience more in person than over the phone, because over the phone, it's a little frustrating, it's hostile, and it's a little irritating because they are dealing with a lot of different people, and it hasn't been really cool because either I get hung up because they don't want to answer the call, or I get yelled at because of the frustration of them answering these calls. So it's been a very bad experience, and I deal better in person than over the phone.
It's been very easy, accessible. It allows you to be able to be anywhere, anytime, of the day to do it. The only inconvenience of it has been that a lot of times I'm not in a private place. Right. And so it's difficult sometimes to discuss, sensitive information and go into detail about it because of that. But
were you able to get to all your appointments?
Yes, very easily.
You didn't miss any of them?
No,
okay.
No.
I missed some appointments. I woke up late, and at times I was busy, and they called at the wrong time a few times.
Okay.
So I wasn't ready for the calls because I was either sleepy or I just wasn't available to answer the calls.
How do you usually use telehealth services?
I use it for getting my medications, calling the pharmacy. I use them
over a personal computer, a cell phone app?
A cell phone app.
Mostly through my phone, but one time I used my laptop because I had good Wi-Fi then.
Have you experienced any barriers or challenges to receiving the telehealth services?
Only the quality of my phone, really. My phone is old and it gives me some problems sometimes, but that's the only problem I've ever had is my phone like losing charge or something randomly.
No computer, sometimes no internet. And I've left my phone number with them because that's actually what they need is my number to call back. And my messages weren't getting across to the doctor. They weren't getting passed along. They weren't getting received. And my doctor, and I would ask my doctor, and he said that he didn't receive no call.
Did a provider, meaning a doctor, a nurse, a counselor, or a case manager, offer you telehealth services?
No, I have a primary doctor, and I just go to the doctor as needed. I consider an outpatient.
Do you know why telehealth services were not offered to you?
They didn't offer me telehealth services because I have an ability. I can walk and I exercise, so I can bike. I can use public transportation or private transportation. I still have a license to drive, so I can drive. So there's no reason for me to use telehealth.
Was it easy or difficult to get telehealth services during COVID-19 pandemic? Do you want to elaborate a little bit, please?
Things that if I ask my providers any information about any situation, I get accurate answers back, and I feel comfortable in doing so.
not too difficult, not too easy, because at times I wasn't available, and I have a sleep disorder. I was waking up late, so not all the calls got to me, and I missed some appointments.
Would you prefer in-person or telehealth appointments?
Both, really.
You like them both?
Yeah, the option.
You like having the option?
Yeah, I like the option would be nice.
Okay.
If you ask me specifically, I probably would prefer in person.
Okay.
As opposed to
in person
telehealth. But it would be nice to have that option for various reasons.
Right.
In person.
Okay.
It's more, I get it more verbally across in person, and I like eye contact.
In person.
Why?
In person, I think it can be more accurate. They can see me and see me express my concern about a situation instead of over the phone. So I think all my services, if it can be, will be better in person.
Does telehealth work well for you?
Well, again, telehealth for me, why it doesn't, because I can't see the person individually. We can just, over the phone, we can just hear in conversation back and forth. I think in person, it's be more, to me, as being more effective.
Telehealth works well for me when I know I'm not able to go to my appointments due to my own lack of energy or something.
Lack of what?
Energy.
Energy.
It could be a lack of energy or my busyness. It could be my busyness interrupting everything. So my overall, telehealth is good for me. I like telehealth.
It just didn't work because either they were irritable discontent or they were just not answered.
Okay.
Thank you so very much.
Thank you.
So I again want to thank the participants who gave so freely of their time to be part of the video, and the staff that have that conducted the interview, Mikey Cativo, Mark Carrasco, Cheryl Hoffman. We also had some behind the scenes help from Fernando Gutierrez and Emilio Rodriguez. When I listen to the video, I can see that a lot of the feedback on telehealth was mixed. What was interesting was that echoing what Dr. Solomon was saying in his presentation, the phone seemed to be the gold standard. There was only one person who commented about using their computer and only once, and the rest of the time everybody was using telehealth via a phone. And that I found was really interesting, because sometimes when you think of telehealth, you think of all or nothing. You're either on a computer and a laptop with video or in person. And it's from the earlier presentation as well as the consumer video, it really seems that most people prefer the phone. But when asked about their preferences, again, there was, even those that had really positive telehealth experiences, the preferences were overwhelmingly in favor of in-person. There's really only one person who preferred telehealth moving forward, and that person stated that at times they don't have a lot of energy to make it to an in-person appointment. But other than that, the people preferred in-person appointments. And what was consistent over several of the consumers was what was mentioned earlier, the eye contact, that they wanted to see the person and they wanted their provider to see them, and that they really missed having that eye contact. So overall, I again am greatly appreciative that we were able to get a few people to give us their opinions of telehealth, and you know, to help us really think about what's right for the individual as we move forward. And with that, we are going to move forward and transition into the next panel. I would like to introduce Dr. Barnabas. Dr. Barnabas is a professor in global health and infectious disease at the University of Washington and an affiliate of the Fred Hutchinson Center for Research, Fred Hutchinson Cancer Research Center. She is a South African physician and epidemiologist, and her research focuses on interventions in HIV and sexually transmitted infections, treatment and prevention. Recently, her work has extended to COVID-19 prevention. The ultimate aim of her work is to identify effective and scalable HPV, HIV, and infectious disease treatment and prevention strategies to increase access across diverse communities and promote equity in health. Welcome to you, Dr. Barnabas, and thank you for joining us. Dr. Boulware is an infectious disease physician scientist and a professor of medicine at the University of Minnesota. Pre-pandemic research for Dr. Boulware focused on providing the clinical outcomes of HIV/AIDS related to meningitis. He has active research collaborations in Uganda, South Africa, Ethiopia, Brazil, and Indonesia, leading to a multidisciplinary and international research team. Welcome to you, Dr. Boulware. And our final panelist is Dr. Kistler. Dr. Kistler is an assistant professor in the Department of Public Health at California State University and a research scientist at Friends Research Institute. Her research focuses on designing, implementing, and evaluating interventions to move disproportionately impacted populations at risk of living with HIV across the HIV prevention and treatment continuum. And I welcome to you, Dr. Kistler. And we will start with Dr. Barnabas. You are muted, and
how about that?
There you go. Okay, there you go.
Thank you so much. It's a real privilege to be here, and I appreciate the kind invitation. It's quite exciting to be, I haven't been at all of the conference today, but it's quite exciting to hear the presentations, especially to hear the focus on health equity. It's my pleasure today to tell you a little bit about a completely remote clinical trial that we conducted early on in the SARS-CoV-2 COVID-19 pandemic. And this trial was to test hydroxychloroquine for post-exposure prophylaxis to prevent SARS-CoV-2. And many people who are in the meeting today, including Rafi and Brian Wood, were part of the study, and Dr. Boulware will talk about a study that started before us, and also a host of studies to test repurposed medications to prevent and treat COVID-19. So early on in the pandemic, I'll take you back to March 2020. We were thinking about what was happening within the community to engender SARS-CoV-2 transmission. And so we thought, and we had some really early data that estimated household transmission occurred in about 15 to 35% of cases. So here in this diagram, individuals who are yellow are considered SARS-CoV-2 infected, and the green individuals are SARS-CoV-2 negative, and the solid line is indicating transmission, and the dotted line indicates close contact but no transmission. And it was the purpose of the work to identify agents that would interrupt transmission at community level within households and thus be a complementary mechanism to vaccines and treatment to limit the spread
Dr.
of
Barnes, we're having a little technical trouble. We need to advance the slide to catch up with you.
Oh, can you not see my screen?
Well, we are now, but it took a minute. There we go. Now
Okay.
we see the yellow and green people in the homes.
Okay, great. And am I advancing? Can you see me advance the slides?
No, I think we're advancing on our end. So if you could just let them know when to advance the slide.
Okay. I see my participant screening is sharing is disabled. So I'll
go ahead and share.
Okay, great. Thanks so much. Great. I think you're sharing, and I'll just indicate when we're moving to the next slide. Thanks for advancing them for me. So we wanted to test hydroxychloroquine for post-exposure prophylaxis for SARS-CoV-2, and this was in a slew of trials and testing different types of medication and essentially using repurposed medication to prevent SARS-CoV-2. What we liked about hydroxychloroquine was that it was very safe. 6 billion doses of hydroxychloroquine had been given worldwide, and it was widely available. So we could think about this as an intervention to prevent SARS-CoV-2. And we conducted a multi-site, double-blind, controlled, household-level randomized trial. And between March and August, we recruited participants from 41 states and overall had excellent retention, more than 90% retention over 14 days, with more than 90% of swabs returned and tested. And these were tests done by PCR, and participants self-collected their swabs. And so this is really quite an intense study for participants, and I'll tell you how we were able to do the study remotely. May I have the next slide, please? So we enrolled participants who were either household contacts or social contacts or healthcare workers, so people who had had contact with someone who had a diagnosis of COVID-19, and they were randomized by household to either get 14 days of hydroxychloroquine or the control, and in our case, we used ascorbic acid. And participants took the medication every day for 14 days in both groups, and then every day they self-collected a mid-nasal swab, and every day completed a survey with this, of their symptoms, and they completed the survey online. Next slide, please. Although, yeah. This slide shows you some of the study procedures. So we recruited participants through health systems, social media, and for social media, Facebook was by far the most successful social media recruitment tool that we had. And this allowed us to recruit participants across the country. So we could look at the map of SARS-CoV-2 incidence, and we could direct the social media to areas with high incidence. Participants were able to sign up for the study on the website, and then and they provided us their contact information. We contacted them by phone or text message, and then we had a telemedicine visit to complete the e-consent and to do the telehealth visits. Participants received a box by courier, and this is what the box looked like. It had a quick start guide. It had their medication in the box. The pharmacy was able to conduct the randomization, so they would get whatever medication they were randomized to, and then they self-collected a swab. Here's a picture of the swab. They put it into the numbered tube. Each tube was numbered for the day, and every day they completed their online symptom screening and their adherence monitoring. And then they packaged these swabs up, and every 5 days they packaged the swabs and they returned it to us. The swabs were collected by a courier. And so there were just an enormous number of swabs and lots of logistics for participants, but they did a really fantastic job at participating and collecting all these materials. Participants really enjoyed the telemedicine aspect of this visit, and we were able also to use telehealth to conduct all our safety visits during the study. Next slide, please. And these were the results that are widely known. Between the two study groups, there were 53 infections in the hydroxychloroquine arm and 45 infections in the control ascorbic acid arm, and there was no difference in SARS-CoV-2 incidence by study group. So there was no effect of hydroxychloroquine. This was an entirely flat study, and so there was no effect at all of hydroxychloroquine on either acquiring infection or on symptoms. Next slide, please. So we were able to report the primary results of the study, but we were also quite interested in whether these remote methods can promote a more diverse group of study participants. And this is really the focus of what I wanted to share today. So we combined, at the same time as this prevention study, we had a companion study for treatment for COVID-19 using hydroxychloroquine and azithromycin, these repurposed medications using the same trial methods with participants self-collecting their swabs and having telehealth visits. Using the social media was quite successful. More than 300,000 unique observers clicked on online recruitment adverts, and we were able to recruit 1,160 participants from 41 states. So we had quite a wide reach. And participants shipped over 14,000, 90% of expected nasal swabs, and completed over 17,000, more than 90% of expected daily surveys over 14 days. So this is really limits the amount of missing data in this clinical trial. And then we were able to compare the demographics to a concurrent clinic-based convalescent plasma study, which I'll show you in the next slide, please. And here we can see on this slide the number of participants by age, racial identity, Hispanic identifying, primary language, and community for the COVID-19 PEP and early treatment studies and for in-clinic. And you can see that with the remote clinical trial, we were able to recruit participants who were younger. The mean age was 39 compared to 51. There was no difference in sex assigned at birth. When we looked at racial identity, we were able to recruit significantly more people who identified as Alaskan Native, American Indian, and Black within this specific cohort using these methods. We also identified more people who, we also recruited more people who identified as Hispanic, 21% compared to 4%, and more people who had a primary language of Spanish, 8.5%, compared to actually none in the clinic arm, no people. And we also looked at the zip codes, and we were interested in whether we could recruit more people from outside of urban areas, and we were able to recruit just over 5.5% from peri-urban areas compared to the in-clinic recruitment. So overall, the population was more diverse using remote clinical trials methods. Next slide, please. And this heat map shows the location by the 3-digit zip codes. The yellow circles show where the clinical trial sites were. So these were all our partners across the country, including here at UCLA. But you can see that we were able to recruit a good number of participants from Texas, where we had no partners. We also recruited a couple of patients from Alaska and from across the country from 41 states. Next slide, please. And we were able to do this in everything was all clinical trials were compressed during COVID, but we were able to do this quite quickly between March and October of 2020. Next slide, please. And the next slide. So I've shown you some data today that support that remote trials can help us recruit diverse trial participants. We had high fidelity to the protocol and the procedures. We were able to do safety monitoring successfully using these remote trial methods. Of course, it's not ideal and suitable to all types of clinical trials, but for this specific trial, it allowed us to recruit participants across the country. It limited also the use of clinical space, which at that time we did need for patient care. There are limitations to these data. It was a post-hoc comparison, and we didn't capture the change in personnel or participant time for study involvement. But these methods, as we heard earlier from all the participants today, and as Gifty said, these remote trial methods are here to stay, and they can help us improve research, equity, and inclusion of participants from more diverse racial, ethnic, and geographic communities, and additional trials will provide further evidence. I want just in the last few slides to thank all the study participants. In the next slide, please. All the investigators, the funders, and in the final slide, please, everyone who helped with the study. And I'm very happy to take questions and answer questions in the chat. Thanks so much for your attention today.
Thank you so much, Dr. Barnabas. That was so fascinating to see how successful the study was using remote recruitment, and what a wide range of participants you had across the United States. It was really an example of how you can have a clinical setting in one location to mail back all of the biomarkers, but yet you can reach people across, any domain through this method. And clearly you did have a wider range of participants using these remote options as opposed to in person. Because in person, you are really limited to where you are in that one particular brick and mortar site, and you can only access the people who can reach that brick and mortar site. So thank you very much for your presentation. We're going to move now to Dr. Boulware.
Great. Well, thank you for the invitation to talk today. And you're going to hear a kind of a similar story as Dr. Barnabas's experience. Thank you very much for the invitation to speak today. You're going to hear a very similar sort of experience as Dr. Barnabas's experience. And I want to talk less about the results of our trial than a little bit more about what we did. And so we ran basically 3 different hydroxychloroquine trials. This is back in early March and April of last year, looking at post-exposure prophylaxis, looking at early treatment, and looking at pre-exposure prophylaxis among healthcare workers. And we enrolled almost 3,000 participants, and basically using telehealth, using remote internet-based trials. And the total cost of these trials was less than $300,000. And so a fairly inexpensive, efficient way to do pragmatic research. And so I want to share some of the lessons that we learned. And so these are the publications. They came out in June, July, and eventually in October. By October, no one was really interested in publishing much in the hydroxychloroquine realm, but the trial was completed in July. And our overall timeline, I kind of want to share, how we did this and what's the role for the future. And so and what's the, how can we really answer pragmatic clinical questions? Because a lot of times the pragmatic clinical questions are not the things that NIH necessarily wants to fund. It's not sexy enough, it's not novel enough, but it's a clinically important question. And so what's the potential role for these internet-based trials in the future? And so our timeline, we started on March 9th I got back from a study section in DC, and at that point there was community spread starting to happen. But I'm from Minnesota, and so there was like, I think about 8 cases. There was, very few cases in Minnesota at the time, but it was apparent that things were going to get much worse. And so I talked to some folks at NIH, and they were focused on their remdesivir in hospital studies. But what about prophylaxis? And so we thought about prophylaxis, and then we rapidly launched a trial on March 17th. And then it was apparent that by the time people were after exposure, they're already becoming sick. And so we said, well, let's expand this to an early treatment trial. And so that started on March 22nd. And those trials ran for about 6 weeks and finished on May 3rd. We rapidly wrote them up and submitted them to some journals on May 6th. And eventually the first one was published about a month later. And after that, we started a pre-exposure prophylaxis trial. What about healthcare workers? What else can we do? And so that started. That project started on March 20th, and basically the trial started on the 6th of April was the first patient enrolled. Went for 3 months of follow-up, and then by July 17th, the trial was done as well. And so fairly short time frame. And a lot of patients, and a fairly small team and an even smaller budget. And so how we actually did this was we basically did an online screening survey, and we used a REDCap database. And basically people self-screened themselves, enrolled in the trial. They did an online e-consent. We shipped them the medicine, and we did a series of follow-up surveys afterwards through 14 days. And we primarily used patient-reported outcomes. And we used a combination for our third trial, a combination of email or SMS messages for the follow-up. And so the automated screening, so this was good in that it enabled a lot of screening, and most people were not eligible for a trial, and it didn't take a lot of resources to screen this because it was all self-screening. And so it was basically a 2-part screening. So there was a screening part, and so that really assessed the inclusion and exclusion criteria. Most of those were not publicly posted, and so we assumed people were being honest. But because that, you could only really go through once, and then you had to submit your answers, and then basically there was a calculated field variable to determine the eligibility, and they basically sent back an email message saying you're eligible or you're not eligible, and so that helped verify that they had a working email that they could follow up with, and if they were eligible, then they had a follow-up URL to go for enrollment. And so overall, we screened almost about 7,000 people for this study. And so this is all via social media, Facebook, the same things that Dr. Barnabas did. And we enrolled about 1,300 in the first 2 trials on pre-exposure prophylaxis and early treatment. So most people were automatically screened out. Of the people who were eligible, there was a human being that went through and looked at their criteria to make sure that this was correct. We also verified that they didn't submit like a dozen different screening criteria to make sure that they hit the correct eligibility criteria. And so there was some sort of QC that was involved, but the vast majority of people were screened out automatically. One of the things that was quite interesting is that this was, because they could self-screen at any point of time, that 2/3 of the participants actually enrolled outside of the weekday working hours. And so the vast majority of people, from 5 p.m. Central Time Zone to 8 a.m. the next day, they were enrolling on evenings and weekends at home time. And so I think that really helped our enrollment, because if we just were relying on sort of normal working hours to call people back, we would have missed a lot of people. And so when you look at the time from when they enrolled overall for shipping out medicines and things like that, the average time was about 36 hours, but that kind of meant that the average person enrolled at 10 p.m. at night Central Time Zone and got their medicine 10 a.m. local time. So that was kind of something unexpected, but I think it was a lesson that a lot of people that work or their business that might want to participate in a research study just are busy during the daytime. And so the follow-up, we basically had a series of follow-up automated emails that went out based on the consent time. The PrEP trial for pre-exposure prophylaxis used weekly messages. And about, I'd say 75% of people overall did pretty well of responding to all the emails they were asked to. About 15% of people needed additional prompts. So follow-up emails, we text them, call their next of kin to track down. And about 10% of people were just sort of lost to follow-up. And one of the things that we learned is that people don't really understand the concept of intent to treat analysis very well. that once they consented and were randomized, really, we wanted to know their outcomes regardless of what happened. And so the consent form is talking about, oh, you can withdraw at any time point. That's great. But at the same time, like, I think most people think, oh, I stopped taking the medicine, so therefore you don't want to know my outcomes. And so in our follow-up emails, sort of, we kind of specifically addressed this, realizing that people had side effects and they'd stopped the medicine. And so we specifically said, like, hey, even if you stop the medicine, we want to know your outcome. And so that concept of sort of intent-to-treat analysis, most people didn't get. And so I think the consent form and sort of a follow-up communications, we targeted, and we kind of learned over time a little bit how to tweak that. But we probably should have tweaked it earlier. We also did remote PK collection. And so like Dr. Barnabas did remote viral swabs. We would have liked to do that, but we did not have the budget for that. But eventually we did find, by the third trial, we did find enough donors to fund our studies as opposed to not having a funded study. And so we're able to do, remote PK collection. So there's these kits that are sort of pre-packaged, nice, sort of, you can do sort of self pricking of your fingers and collect capillary whole blood. So we were able to do some hydroxychloroquine pharmacokinetics. And these kits cost about $25, and we basically would mail them out to people, then include a FedEx overnight ship back to us. And we would have liked to do viral loads, and other colleagues are doing that now. And so even remote collection, I think, is possible for blood and other things. The endpoints we used were pretty simple and straightforward, and we used basically patient-reported outcomes. And so for the pre-exposure prophylaxis trials and post-exposure prophylaxis trials, people start out healthy. And so the question is really, do they get sick? And so the questions were fairly, simple of, are you experiencing COVID symptoms? And then sort of like, what are the symptoms? And like, do you have these? We looked at severity using a visual analog scale, which is relatively straightforward. So it's a 0 to 10 scale. It's a built-in function, red cap. And we asked about side effects. And then if they said yes, then we have sort of a checklist of what are the common side effects, and then provide some pretext box as well. And then asking about, are they hospitalized? And then assess, some medications. And then at the end of the study, we also assessed the adequacy of blinding of what they thought they had. And via red cap, we also, once the trial was completed, we also, were able to tell them what they had. And so I think people also like that, like, oh, I was on placebo, or I was on hydroxychloroquine. And so we're able to use that to inform the final study results and the randomization that people are always curious about in a double-blind study. So for the role of virtual trials in pandemics, this has obviously been huge. We use patient-reported outcomes, as have some other trials. The UK recovery trial, which is well known, used clinician-reported outcomes for the most part. I think this is really good for pragmatic, get the clinical answer you care about. They're not so great probably for registrational trials where you need more safety monitoring. And you really kind of need a good safety profile of medicines. And so if you need laboratory monitoring or other stuff, it's a little bit complicated. You could do some subgroup analyses of doing safety monitoring, but I think you really do need an existing medicine with a known safety profile that's safe to give. And you need the ability to recruit. And so this is, I think, what every trial really stumbles with. And so I think for virtual trials, you either need a rare and neglected disease where you have really motivated participants, or you need a strategy trial that you have motivated investigators that really kind of want to know the answer. And so I think moving forward, that there's a vast potential for this, for both of these issues. Some of the strengths is that it was really very pragmatic. We didn't ask every question on this time. We really kept sort of short questionnaires, focused on the clinically relevant questions. It was very low cost, and really enabled broad participation. And just as Dr. Barnabas's experiences, we had recruitment all across the country. Here are some basically states. I think, unfortunately, no one in Montana, Nebraska, or Vermont liked us, but we had inquiries from Guam and Puerto Rico and elsewhere of, hey, can we participate? And we said, sure, Puerto Rico, that's fine. We could ship you medicine. So we had pretty good participation all over the country, Texas and Florida as well. And this was relatively early in the pandemic. Some of the challenges, I think, inclusion and exclusion criteria have to be really simple and patient reported. So if you need laboratory values or something like that, that's not going to work. You can be a red cap, have people email in documents for proof of testing or things like that. In the pandemic, it's hard because some people were notified over the phone, so you may not have a document. but you can certainly submit that. Informed consent, so we use an e-consent online, which FDA does allow and has some recommendations for. But we also did assess their comprehension of the consent. And so I think this is important that we didn't have a form that they clicked and said, oh, yes, I agree, take my first of kin and my firstborn child and whatever, that, we wanted to actually have some informed consent. And so we did sort of, have a multiple choice questions of sort of some of the basics of the assessment of comprehension. So they kind of knew what they were getting into. And that may not be perfect, but I think the kind of the gist was there, that of the key kind of critical considerations that people understood what they were consenting for. We also asked for consent for access to their medical records. If this trial was successful, which I guess it was successful, it got an answer, but it wasn't, hydroxychloroquine was not effective. We wanted to be able to verify sort of the endpoints if we needed to go back to people's medical records. And the other thing is you really do need straightforward surveys and do sort of the user accessibility testing beforehand. And so we did have a lot of non-medical people sort of chime in and sort of review sort of the questions and like, did they understand what we're asking? And obviously we rely on honest participants, but you have dishonest participants. But that's where blinding and randomization are really important, and they're really key. And so let's say there were people that were dishonest, presumably they would be randomized equally in both arms. And so that should not skew the results. So for more information on our trial overall, we did write up sort of some of the lessons we learned on sort of how to conduct an internet-based randomized clinical trial during a pandemic in OFIN and open form of infectious diseases. And would be happy to answer any questions at the end there. So thank you for listening.
Thank you very much, Dr. Bulwer. And what I was struck by when you were talking about, who enrolled and how they enrolled, that similar to Dr. Barnabas, who was able to reach such a diversity, you were as well. And that point about outside the regular workday hours, I think that's quite significant, because not only are you able to reach a wider range of participants, but you're able to reach participants on their time, evenings and weekends. And so both of these play into the limitations of in-person clinics. If treatment is limited to these in-person treatments, or a study is limited to it, to these in-person treatments and a brick and mortar clinic, you miss so much. And I personally want to just take a moment to thank you and to thank Dr. Barnabas and also Rafi, and all of you infectious disease doctors who jumped on COVID-19 early in March 2020. And I don't think we would be here where we are today in June 2021 without the dedication of you infectious disease doctors. And it's quite strikingly clear as we see your presentations how much work y'all did so early on. You saw the need, you had, you were well aware of where this was going and you jumped on it. So thank you very much. We're now going to switch gears to Dr. Kistler's presentation. Dr. Kistler is going to talk about behavioral research study with Black men who have sex with men who are living with HIV and the consequences and outcomes of in-health versus virtual. Dr. Kistler.
Thank you very much, Dr. Reback. Wow, some really impressive work to follow and definitely shifting gears. I'm here to talk to you about a study called Building Brothers Up, and as you see, the experiences were quite different.
You take a cleaning class?
So first, some background information. We were one of 8 demonstration sites that were funded by HRSA Special Projects of National Significance under an initiative aimed at adapting and implementing evidence-informed behavioral health models of care for BMSM who were living with HIV. And we conducted this work at Friends Community Center, which is the community research site of Friends Research Institute. And you actually got to meet some of our fantastic participants in the consumer video that you watched earlier. So I'm not going to go, I would love to give you this long overview of the adaptations we made in this particular project, but I'm going to save that for another presentation. And so just a little information, we adapted the model of care called youth-focused case management, which was actually an intervention designed here in Los Angeles at the Department of Public Health. And we called our adapted version Building Brothers Up, or 2BU for short. So let me give you just some basic understanding of what 2BU included. It was a 6-session intervention that occurred across 3 months. And so the first month included weekly sessions, so that would be sessions 1 through 4. And then in months 2 and 3, they received sessions 5 and 6 respectively. And so at that first session, a peer case manager worked very closely with the participant to identify any needs or barriers that were impeding advancement along the HIV care continuum. And in that, they developed a participant-centered treatment plan that they would then work on across the 6 sessions. And the remaining sessions, 2 through 6, were kind of revisiting that participant-centered treatment plan and revising as needed. And the ultimate goal was to really link someone to HIV care if they were not already in care, get them on ART, get them adherent, and then also to focus on really identifying the behavioral health and support service needs, so that that was really integrated in helping them to advance across the HIV care continuum. The eligibility criteria, we were targeting Black men who have sex with men who were living with HIV between the ages of 18 to 65. And we had a relatively kind of wide version of who qualified in terms of where they were at on the care continuum. So they could be not in care at all, or they could be at risk of falling out of care. And there were lots of ways that we qualified that. It could be not employed, it could be using active substance user, things of that nature. And we have concluded our enrollment and implementation. And so I wanted to just give you a very basic overview of the sociodemographics of our group. As you remember, 18 to 65, and we had pretty fair representation across each of those age group breakdowns. 86% had at least Medi-Cal or Medicare, so a pretty high group of folks with insurance. And then 75% had at least a high school diploma. So that gives you just a little context of who we're talking about when we talk about the success of telehealth with these guys. So before this COVID pandemic hit, we created a fully in-person intervention. And that is because at Friends Community Center, historically, that's really what has worked best for our participants. We also have found that it's a great gateway for programs on site to conduct in-reach and refer participants over to other programs. And then it's really nice for participants to access services that are co-located in an in-person setting. But as we're all well aware, COVID-19 hit and sort of shifted everything. And so as we all went home and started figuring out how to do remote everything, we decided to try and transition 2BU to what we called a fully remote or virtual delivery. And so this was delivering all of our services, and that included, anything related to assessments and evaluation, as well as the intervention, either over the phone or via Zoom. So just a couple of examples of the ways that we adapted for more of a telehealth delivery modality. All of our recruitment, which we traditionally had done, in the streets, at venues, had to be shifted online. The screening process, which we often did with a person on a tablet live, needed to be done over the phone or Zoom. Enrollment was a little complicated because we needed to figure out how to do the informed consent procedures and how to pay out gift cards for incentives for participating in the assessments. And so we decided to go with DocuSign, and that took some struggle just finding something that was approved by the IRB so early on, as well as just transition from real gift cards to electronic versions. The assessments, there was a baseline, a 6 and a 12-month assessment, as well as local brief assessments at each of the peer case management sessions. Those had originally been done in person, the participant self-administered with the staff person right there to help answer any questions. And that was no longer possible. So we would send a link to a participant and they would do the survey on their own. We hoped they would do it with us while we were on the phone or Zoom with them, so we could answer questions or address any literacy issues, but they also could just do it on their own time. And then we set up a system that would alert us when the assessment was completed fully, and then we would administer an electronic incentive. And then all of the peer case management sessions and referrals and handoffs would occur over the phone or Zoom. So this is just a very simple table kind of showing you the success of implementation pre-COVID. So we actually began the end of October 2019 and only had a short span of time until March 11th, 2020, when our organization decided to convert to remote work, to telework. And so you can see we were well on our way to reaching our enrollment numbers. Folks were coming in, they were enrolling, they were screening, they were coming to their sessions. But once we went into the telehealth delivery and we concluded enrollment in December of 2020, which was just a huge surge here in Los Angeles, things kind of opened and closed and opened and closed. You can see that things didn't quite pan out as well as the pre-COVID phase. And so I want to just draw your attention to the screens. We had 17 who were eligible, not interested, and they actually cited that the technology utilized for telehealth was one of the main barriers for not wanting to enroll, and the remote delivery. And then also, we had 4 withdrawals. Pre-COVID, the only withdrawal was a PI withdrawal. And then during the COVID phase, we actually had 3 participants who decided to self-withdraw because they just did not like the remote delivery and they had barriers related to the telehealth technology. So, as I mentioned, we transitioned everything to this fully remote virtual modality, and unfortunately, our participants just did not respond well. And so, this has been a running theme throughout this entire conference, but we decided to create what we deemed a hybrid version of the intervention, which essentially was allowing participants to choose the modality of delivery that worked best for them, in person or over the phone, over Zoom, or a combination of whatever they felt was the best for them. So we, as I'm sure all of us have in the past year, learned a lot of lessons. For our intervention, we really discovered that the remote virtual delivery, it really presented a lot of challenges, and the in-person delivery was really most successful. And, I'm not going to reiterate what folks have said already, but, access to internet, huge issue. Finding a time and quiet space without distractions. If you're engaging in a peer case management session and you're talking about really private things, finding a space when a lot of people were sharing homes at this time, dealing with evictions and saving money, to be able to do what could be done in a private office space wasn't really possible in a shared living environment. And then they just experienced a lot of issues with the technology. They didn't necessarily feel knowledgeable or confident in accessing email or using DocuSign or using the Zoom technology. So we have talked at length, and I think a lot of the messaging has been like, telehealth is the future. This is amazing. And it has certainly been great. I mean, some of us are going to work in our, shorts and our comfy clothes on the bottom, and participants and people are able to access services remotely. And so for many, it's really, really wonderful. But we have to remember that it's not necessarily great for everyone. So the future considerations is if we only focus on this new sexy telehealth modality, we're going to miss out on serving a lot of folks who still need services. And there are certainly, digital divides that exist, and I think that they're very real, but we can't always predict based on someone's educational status or all of these other factors, whether or not they're going to just want to come in and talk to a person in real life, or if they're going to prefer something at home. And I think that's really shown in the sociodemographics of our particular sample. So we really need to make sure that we are continuing to offer options. Again, this has come up repeatedly throughout this mini conference. But if we do offer these telehealth, remote, virtual deliveries of services, and not just clinical services, mental health services, behavioral health, participation in interventions and other kinds of social and other support services, we need to help people feel comfortable and enhance the literacy around successfully using this technology. And it's not just access, right? It's not just having a phone or having a place like these portals set up at libraries. That's a really important piece, but it's also just teaching people how to use things. We had so many participants who didn't have an email. So we needed to walk them through setting up an email address. We needed to teach them how to use DocuSign. You know, we had to teach them how to download an app and then how to use Zoom, what all the little buttons meant. And so if we're going to deliver, just like we spent so much time kind of focusing on helping people get into brick and mortar spaces, we also need to focus on teaching people how to utilize this new telehealth technology. And as my peer case managers can attest, it takes a lot of time and patience and cannot be an afterthought. It really needs to be integrated into the planning of intervention delivery. So with that said, a huge shout out to especially my co-investigator, Dr. Cathy Reback. Several of the team are on this call, so thanks to all of you. And thank you to all of you for listening to this presentation.
Thank you, Dr. Kistler. I think the experience you had with the 2BU study is so important, and you have an important message for people to hear. It's interesting to contrast that to the success of Dr. Bulwer and Dr. Barnabas's study, and perhaps a lot had to do with what Dr. Bulwer commented on rare and neglected disease. And there was a tremendous motivation to bring people in to these studies for COVID. We were all living through it and we all were involved. And here you were working with people who were living with HIV, many for many years. And it was an entirely different population. But I think it is very interesting to contrast what happened pre-COVID in your study, which was 5 short months, and you practically enrolled, half of the sample, and then post-COVID, which was 9 months, and it was almost a standstill. But thank you all very much. Unfortunately, we're running out of time. We must get to Dr. Veniegas's comments. So I am going to encourage all of you with questions to please put them in chat. We're going to review the chat and we will respond to all of your questions. Nothing will get ignored. And I thank you all for participating. Does anybody have any last words before we go to Dr. Veniegas? All right, thank you again. And I want to remind all of you out there that we do have another raffle coming up after Dr. Veniegas's talk. And it is my pleasure to introduce Dr. Rose Veniegas. She is a senior program officer with the California Community Foundation. And prior to that, she was an assistant research psychologist at UCLA in the Department of Family Medicine. And the work that she conducted in that capacity addressed the implementation and evaluation of evidence-based programs and practices in community and public health setting. She is a colleague of many of ours, and thank you very much for giving of your time to join us today.
Thank you very much, Dr. Reback, Dr. Landovitz, and also all of the members of the Center for HIV Identification, Prevention, and Treatment Services that made today's event possible. I want to reflect back on the early comments and welcome to the circle that exists on this Zoom today. Juneteenth and the recognition of Juneteenth Independence Day reflects inequities that were baked into the United States. The reason why Juneteenth exists is because Union soldiers were finally able to notify enslaved African Americans in Galveston, Texas, 2 years after the Emancipation Proclamation was passed. Fast forward to Dr. Wood's comments about the digital divide. And we know that companies that invested in broadband and Wi-Fi and the technology that makes it necessary and allowable for us to provide telehealth services did not invest in communities in the equivalent of digital redlining. And similarly, when loans were made by banks to communities to allow people to establish homes and be able to buy into their communities and create generational wealth, banks and loan officers refused to provide loans to African Americans, Jewish people, and other folks whom they considered would not be desirable in our communities, including here in Los Angeles County, California, and across the US. So the community, cultural, and societal context in which we are now evaluating the effectiveness and applicability of telehealth exists in this moment in time as we recognize Juneteenth Independence Day as a nation. And so I appreciate the comments that have uplifted equity throughout your presentations. And as I listened to each presentation, including the consumer voices that were curated for us in a beautiful quilt of videos, I really reflected on the equity issues, the integration issues, and the policy and finance issues that lay ahead of us as a community, as researchers, as scientists, as advocates, and as people who believe in the power of people to advance the quality of care, prevention, and treatment services in our society. And so I reflect, I think, on the comments that have been made by the consumers who said, I prefer having the option of both. Let me choose. And the research that's been presented today echoes work that's also been presented by the California Healthcare Foundation with regard to what low-income Californians want regarding their healthcare. They want behavioral health providers whom they feel comfortable talking to, whether in person or via telehealth. They want people who will look at them in the eyes. And how difficult is it on Zoom? I think you can see that I'm trying to make eye-to-eye contact with you right now. I'm actually looking away from the content of our presentation in order to deliver these words. And that's really the experience that many of our community members, clients, patients, even our fellow colleagues who are receiving training in how to deliver telehealth in a way that's compassionate and culturally responsive. Making that personal contact, whether you do it remotely via virtual or in person in the same exam room, matters so much to delivering what we all believe in. The right care or right approach to the right person at the right time. I appreciated Dr. Solomon's comments about how telehealth can help to advance work even in the midst of crisis, even in the midst of the pandemic, through Project Roomkey, which was implemented to provide stable housing to individuals during a time when it was believed that people experiencing homelessness would have higher risk for becoming exposed and severely impacted by COVID-19. Project Roomkey represented a clear health pathway expansion here in Los Angeles County, where providers went to where people were, physically went to where people were, provided access to medication-assisted therapies, provided telehealth as well as in-person, and then also provided continuity by following folks as they were transitioned perhaps to other sites or were coordinated with other providers. I appreciated also the comments with regard to changing policy. Policy is what will make a difference in all of this. And the data that each of you have gathered, are gathering, will gather, and can share in the future will move not only hearts and minds, but pocketbooks and also legislative decision billets. And so just to offer you a few examples, one of our presenters asked, well, what are some of the policies that need to be changed? First, establishing telehealth parity. Here in California, there's a policy that's been advanced by the governor in order to establish telehealth parity. Yet, federally qualified health centers, including those that Dr. Solomon works at, will not be able to bill for certain delivery of telehealth. Other providers will. And in fact, our state legislative analyst office commented that the proposals made with regard to even our telehealth policy here in California would create inequities within the Medi-Cal beneficiary population, and they lack a sufficient policy rationale. As researchers, as advocates, as consumer advocates, and as consumers ourselves, these data around how inequities will be perpetuated or initiated as a result of policies structured around telehealth matter, and providing that public comment, that public testimony, and serving certainly on some of the input committees and task forces that will result as part of these implementations of policies is critical to the work. While we may not see the immediate value of them, please know that equity baked into policies is extremely powerful. It means appropriating funds for the reimbursements that covers whether or not those swabs that are sent via mail, whether the cost of that return postage is actually something that a clinic, provider, or researcher can bill for. And baking that kind of result into policy is key to what all of us can do together. I appreciate the opportunity today to hear all of these presentations and to take these back to many of the community partners with which the California Community Foundation works. We've supported many of the organizations that have provided resources and support during the quarantine and isolation period of the early phase of the pandemic. We've also worked with other funders to support Project Roomkey and the Health Pathways expansions. And we will continue to support the advocates, including the community members and residents who access the safety net services here in LA County, of which there are over 500,000 residents who access safety net services that would be impacted by policies around telehealth services. And so I congratulate all of you for the work that you're doing. And I also hope to engage all of you in the work that lies ahead of us for equity, integration, and the kind of systems change that we all aspire to. And I, again, thank Dr. Reback, Dr. Landovitz, and the entire CHIPS crew. Dami, thank you so much for preparing us for today. And I look forward to seeing you all in person, in real life, in the very near future. So thank you, everyone. I know I stand between you and the final raffle. So let's turn back to Dami on that.
Actually, just before we go to the final raffle that will close us out, I just want to thank you all for joining us today. Thank you, Dr. Veniegas, for summarizing and re-emphasizing the importance of equity in this work and summarizing all of the perspectives today. I want to thank all of our speakers, our panelists, you all for joining. As you already said, extra special thanks to Dami for organizing us all and keeping us all on track, both on time and on point. I do want to remind everyone that we will get a link to the recording of today's conference for yourselves and for your colleagues that weren't able to join us. We will make sure all of the questions and comments are addressed in a follow-up document. And we look forward to continuing this conversation that we really feel we've only just begun today with all of your input and participation. Again, we really want to recognize CHIPS, who sponsored this, which is sponsored by NIMH at the NIH. And we look forward to sharing other CHIPS-related activities with you all in the future. I'll now turn it back over on behalf of Dr. Reback and myself to Dami for the final raffle. And then we'll set you all free. Thanks so much for joining us today, and have a great weekend.